to try and bring everybody together to talk about how lifestyle particularly can help our patients with type 2 diabetes. So I'm going to hand you over to Mr. Bollywood, and we'd like some volunteers, please, because we're going to do a bit of dancing for those.
I would like to take this opportunity to personally thank the organising committee who've worked so hard to prepare and organise this event. That's Michelle, Natasha, Angela, Ali, Suman and her comms team, and obviously Anna. I'd also like to thank all the speakers who've given up their time to come to speak to us today, to share their expertise and knowledge.
It's World Diabetes Day today, as you know, and there's all sorts of tweets. Television was here earlier on. We had to do some television interviews. And I have to say, there's events going on across the whole of the country. And I think this is the biggest event that's taking place on World Diabetes Day in the UK.
If we do the simple things well, we can reduce all the complications of diabetes. Heart attacks, strokes, amputations, blindness, and kidney disease as well. And at the bottom, we've got a list of key contacts that the person must has locally. So their local community pharmacist, for example, their local Diabetes UK group, or their local dietitian. Page 2 is quite critical. This is very, very patient-centered, and it's about what the patient needs to write down in terms of what they want to discuss. We will go through all this in the workshops as well, so I will go through this very quickly. And the next page is a care plan where people's blood pressures are written down, cholesterols. If they don't know what their numbers are, how can they actually help themselves?
We'll start with diabetes prevention. So famously, Hippocrates tells us prevention is better than cure. Prevention is better than treating. So in this first section, I wanted to highlight some key information, key guidance for us in primary care as GPs, nurses, pharmacists, dietitians, on how we can identify those at high risk of diabetes, okay? So we had some nice public health guidance published a few years ago, and that was updated actually just last year, September 2017. And they suggest a two-stage strategy for us to consider in primary care to identify those at high risk of type 2 diabetes. And then they go on to give us some suggestions on what we can do with these individuals. And the evidence from this comes from large-scale diabetes prevention studies. So the first thing NICE suggests we do is we use a validated risk assessment tool in primary care. So there's several available. There's a Diabetes UK one, of course. There's the Leicester Diabetes Risk Score. To be honest, have to say I use the Q Diabetes score. Some of you might be familiar with this. Q Diabetes 2018. Now, this is the risk score from the same group that does the Q risk score, which I'm sure you're all familiar with. That calculates 10-year cardiovascular risk. So this calculates an individual's 10-year risk of developing type 2 diabetes. What constitutes high risk? A 10-year risk of 10% or greater suggests a higher risk of type 2 diabetes. Two messages on prescribing and these cardiovascular outcome studies. Poison is in everything, and nothing is without poison. The dosage makes it either a poison or a remedy. Very true, isn't it? Of all drugs, diabetes drugs in particular, some of which can cause potentially fatal hypoglycemia. Really challenging now, isn't it, after metformin? We've got this huge range of drugs, each with their own modes of action, adverse effects, potencies, restrictions and renal impairment. So it's really challenging for us to individualize treatment to that person sat in front of us. I ask them a simple question when I'm picking any new diabetes drug. Is this a drug I'd give to my own mother? Or is this a drug I'd prefer to give to my mother-in-law?
So what about expert patients? So, is this an untapped resource, really? We've got 22,000 patients with diabetes in my locality. We've only been able to deliver the validated education package to 800. Can we use skilled patients? So we had a little look at this. Again, this was about 2 years ago now. We interacted with the psychology department at Aberystwyth University, and we ran a small feasibility study using something called the Stanford Diabetes Program, which is not very heavily factually based. It's more about empowerment, managing chronic conditions rather than condition-specific. We picked people that had just been diagnosed. None of them are on insulin. And this is the sort of information that you might expect to see, just some feedback. So excellent tutors, breaking it down into bite sizes over the 6 weeks. I thought I could take control of my diabetes. So this is the last slide, actually. So I think, you know, the film work has been fantastic thing to be involved with, really, and it's been a real pleasure. And if you look through the films that are available, it really does involve patients from all over Wales, and healthcare professionals likewise. Sort of a really very nice resource. But of course, it's not the answer. It's part of a as part of a group of answers, and I think it's part of what we need to be offering is different things for different people, depending on what their needs are at that moment in time and what their capacity is to attend courses, for example. And I think we should encourage people always to try and attend a talk course. They will invariably get more information from that. And clearly there's this emerging evidence with the film's prescriptions, which has been very nice to observe.
We're very lucky to have secured Jeff and Ian Whittington. And if anybody's ever seen the Fixing Dad programme, Jeff is the dad. So without further ado, the stage is yours, Jeff.
Thanks very much. Thank you. First of all, I'd like to thank you all for allowing us here today to talk to you all. I mean, the most I spent is 15 minutes in front of a diabetes professional. And now I've got 500 of you here, and I've got you for 20 minutes, so I'm going to make the most of it. But I don't know how many of you have seen the film. Show of hands, anybody actually seen it? Brilliant. But it's, well, basically it's all down to this guy and his brother. And I'll hand you over to him to explain.
Yep. So in 2013 we started this. At the time, I think diabetes was in a very different place, and you probably wouldn't find this many doctors looking at, you know, prevention in this way. And it was we were really lost with what to do with Dad, because we'd only started actually seeing visual signs of his disease. And it was at that point, after 10 years of mismanagement or just continuous downward spiral for him, we decided we had to do something about it as a family. We owed him as a family, and it was that moment of realising that it was as much our fault as it was his. We're part of his environment, and we had to disrupt that to make sure that he didn't get worse. Dad, how did it feel for you at that point to feel like somebody actually gave a damn about what was going on with your health?
Well, obviously it was you two, and I was obviously very close to you. And when you told me what you wanted to do, I went along with it. I thought, you know, they gave me all these ideas about things they had planned for me, riding a bike again, which I hadn't done since I was a teenager, and all sorts of different things. And I agreed that I would go along as long as I could, and that's it. We started on the venture.
And it really was about reimagining Dad. You know, that was the way we saw it, really. So we started coming up with crazy ideas and writing down how we can do it. We made it exciting, so that reversal journey that we were going on wasn't going to be a negative thing. It wasn't going to be something that we focused on all the bad things about his health. You know, we were going to make it fun, like it was when we were kids, and we used to go out and do things. And that was the point: is that reversing your diabetes isn't something necessarily that's a real chore to do. You know, we all eat great now. We have an amazing food. It's just we do things differently, but it's not necessarily worse, and it's not necessarily, you know, less tasty and things like that, is it? And you enjoy your life now. Absolutely. But we did have to set certain goals, because what we found was, you know, yes, there was the fitness side, as Anthony said. There's also the nutrition, which was incredibly important, but none of that would change without the mind. So you can't just go telling people how to change. You know, you've got to give them the reason why, and that's what we hope that Fixing Dad and going forward with the films we're making in the future will do, is give people the why to change.
In terms of outcomes, do patients on insulin pumps have better glycemic control than those engaged patients who are just on a kind of a usual normal regime?
So the criteria for utilising insulin pump therapy is poor control, so HbA1c, which is suboptimal, or recurrent severe hypos. So control does get better, but interestingly, insulin pump therapy has been the first thing that's been shown to improve quality of life in the management of type 1 diabetes for a long time. So it's not just about, people... I've done a lot of outside of work things with people who are living with type 1 diabetes, and a huge, vast majority of them are on insulin pumps, and it basically allows individuals in that setting to have a completely a life unaffected by diabetes, which I'm not sure necessarily using standard insulin pens does.
So I would like to just touch base very briefly on the pathophysiology and the role of incretin hormones in type 2 diabetes. So, as you know, in healthy individuals, after food intake, there is a release of GLP-1 from L cells in intestine and GIP from K cells in intestine. Also, there is release of insulin and amylin from pancreatic beta cells. GLP-1 and GIP has effect on suppressing gastric emptying. They also suppress glucagon release from alpha cells, and also act on the appetite center in brain and reduces appetite. Now, after there is a food absorption, so absorption of nutrients including glucose, fatty acids, amino acid, there is a postprandial release of these incretin hormones, which then directly stimulate beta cells to produce more insulin. And this effect is called incretin effect. You might have heard about this before. So what it means that if somebody has intravenous glucose, then it will not lead to this rise in GLP-1 and GIP, and therefore there will not be any rise in insulin secretion from pancreas. And it is only seen if you're having some oral glucose load. And it seems that up to 30% of insulin secretion postprandially comes due to this incretin effect related to main two hormones, but maybe other peptides. Now, in type 2 diabetes, this incretin effect is diminished or even absent. Now, it's not quite clear why the incretin effect is diminished or absent in type 2 diabetes, and there's a bit of a debate about it, whether this is a cause of diabetes or whether this is an effect of diabetes. But according to an expert review published in Lancet in 2016, perhaps this is an effect of type 2 diabetes. So basically what they're saying that, in fact, there is no reduction in the postprandial secretion of GLP-1 and GIP. They are released after the food absorption, but simply there isn't enough beta cell mass there in the pancreas to respond to that and produce increased insulin from the pancreas. Some believe that perhaps there may be reduced secretion of GLP-1 and GIP from the K and L cells from intestine. So this is an area of active research.
Your learning outcomes from this session is going to recognize the different insulin therapies, be aware of the insulin regimens, understand how they can be used appropriately. Okay? Thank you. Let's start. So, the early era of insulin therapy, that was 1922, when the doctors from Toronto were on track of a diabetes cure. And these two lovely people, along with their dog Marjorie, who was called later on, they discovered insulin. And lo and behold, that changed and transformed the lives of people. They changed lives because from a cachectic state, you have a very bonny-looking child who was Leonard Thompson, the first person who received insulin. He went on to live for about to the age of 16 and died of complications, but other people received insulin.
So his concerns are his weight, his driving, urine infections, busy and forgetful. My concerns as a DSM would be his compliancy, his weight, HbA1c, BP, microalbuminuria, urine infection, and the right medication for him. His views then, he doesn't want insulin because he thinks he won't cope. He's not keen to test. We'd like to have a weight loss drug. That would be a great idea. Having to keep his job as he's a single earner. As a healthcare professional, I'd be thinking about improving his compliancy, loss of weight and exercise, multifactorial control. We're looking at PIO would be weight gain, reducing or to stop his SU, GLP-1, basal insulin, might give him a bit of weight gain and hyperglycemia, and any others. What are people's thoughts?
Not keen on testing. He should be testing already because he's on glycoside and he's driving. So he should be testing anyway. So,
But do all of our patients test?
okay.
He should be. He should be. We know that. He should be. Yeah.
So what is gestational diabetes? It is, as the definition says, it's a glucose intolerance resulting in hyperglycemia, which begins or first diagnosed in pregnancy. There lies the catch. So what do you think the maternal age is happening in the UK, going up? What do you think BMI is happening for women with childbearing age? It's not even a question, isn't it? So these are the two major risk drivers for diabetes in pregnancy. One of the other other big risk is the family history. Obviously, we can't change that. Hence, not surprisingly, the rates of gestational diabetes going up, but the rates of undiagnosed diabetes, or women with asymptomatic diabetes or pre-diabetes entering pregnancy, is going up. And that's a much more of a worry. At least we know about the type 1s because they have the label, and it is worrying that these women entering pregnancy we have no way of knowing, and the NICE guidelines doesn't support screening in first pregnancy.
So think a safer approach, stop ahead, think, is their AM1C appropriate within the target? Are they taking folic acid? Encourage them to plan pregnancy and do refer them early on, because we have preconception services, and if they're already pregnant, to diabetes team early on.
I've been to various lectures and learnt a lot. I think my sort of take-home message was about lifestyle, that lifestyle is so very important in diabetes, and that we knew before that people at risk of diabetes could have their diabetes prevented with lifestyle changes, and now there's more evidence that in certain patients who are very well motivated in the right circumstance, that diabetes can be put into remission.
Yeah. My two are probably to really empower patients to do that and to make better use of my clinic time. And I really like the talk from Sam Rice, Pocket Medic. When I had the email from Natasha trying to interest South Warwick GPs, I thought that was going to be something that would be more for me to put into my consultations, but now I've discussed it with a few other people, and I can see that that could actually be delegated to my assistant practitioner or my HCA, and that there are ways that we can actually help to empower patients to take more responsibility, more care themselves out there, and to educate themselves further. So I think that's one of my top tips.
Thank you very much for attending today, and cheers, bye.